Good morning, everybody, and welcome to our webinar supporting patient choice for people with kidney failure in partnership with St George Hospital. My name is Bertha Harvey and I'm CPD and Events Manager with Central and Eastern Sydney PHN. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work, who recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. I would also like to extend that respect to any Aboriginal colleagues who may be joining us today. Now I'd like to hand over to Kylie Turner, who is the Chronic Kidney Disease CNC at St George Hospital. Thanks, Kylie.
Thanks, Bertha. I'll just share my screen. Good morning also. I'm Kylie Turner. I'm the Chronic Kidney Disease CNC at St George and Sutherland Hospitals, and I'll be presenting today with my colleague, Dr. Brendan Smyth, who is a nephrologist here also at St George. I don't know if Brendan wanted to say good morning to everyone.
Yeah, hi everyone. So I'm Brendan Smyth, a nephrologist at St George, as Kylie says. I also work at the University of Sydney. And I do have an interest in dialysis and dialysis studies, so happy to be here.
So today's talk, we're going to talk about There's No Place Like Home. So it's about supporting patient's choice for people with kidney failure. So just to start off the session, how these sort of sessions came about was through the St George Hospital Integrated Care Chronic Diseases Working Party. So our group has been formed now for around 4 or 5 years, and it's predominantly about improving that interface between primary and tertiary care. So some learning outcomes from our talk today, understanding modalities of kidney replacement therapy with an emphasis on those that can be performed at home, exploring the evidence in support of home dialysis therapies, reviewing the factors to consider when choosing a dialysis therapy, and an introduction to the pathways leading from pre-dialysis chronic kidney disease to successful home dialysis. So just to talk a little bit about treatment options, so formerly known as end-stage renal failure or end-stage kidney disease. So kidney failure options that we have what we call a conservative pathway, we have dialysis, and we also have transplantation. So just to very briefly just mention transplantation and conservative management, there's obviously predominant patients that these would work for, but they don't necessarily work for everyone. Transplant is a process. There's 2 ways we can have a transplant. As you know, we have deceased donor transplants. We also have live donor transplants. We've also got, as I said, the conservative kidney management pathway. This is a patient choice, but with also some recommendation from your nephrologist. So just a little bit about referring to the Renal Options Clinic. So the Renal Options Clinic at St George Hospital is predominantly run by myself with a social worker and a dietitian who also consult with the patients. Patients are referred by the nephrologist to this clinic, generally when their kidney function is around 20 to 15% and below, or within 12 months of them needing to commence a form of renal replacement therapy. And this pathway here just sort of shows how this sort of process works. A bit of a confusing slide for those that aren't sort of doing the role, but basically them coming to the clinic just sets them on that pathway for where they may end up in terms of their end-stage kidney disease. All the letters that are produced from this clinic are actually faxed to the GP. So if you do see these letters, that's what they're about. That process only started probably in the last sort of 2 years. And the idea is obviously to try and keep the general practitioners in the loop as much as possible in terms of what we're thinking about in future for this particular patient. So kidney replacement therapy options. So now talking about dialysis. So there is actually 2 types of dialysis. We have haemodialysis, where the blood's actually coming outside of the body to get cleaned. And then we also have our peritoneal dialysis, where this actually happens obviously inside the patient's body. Now, both types of these treatments can actually be done at home. So just firstly, just to talk a little bit about peritoneal dialysis. So peritoneal dialysis requires the patient to have a peritoneal dialysis catheter. There are a couple of contradictions to having a peritoneal dialysis catheter. patients who may have had very extensive abdominal surgery may have extensive scar tissue around that peritoneal lining that we're going to use for this form of dialysis. And that would mean that this type of dialysis may not necessarily work as efficiently in this patient. Also, abdominal size can be a contraindication for the peritoneal dialysis. This particular type of dialysis is only done at home. There's two ways that patients can actually have this dialysis. They can have a form of continuous ambulatory peritoneal dialysis, which I inform them is a manual version of this dialysis, where that involves them having 4 exchanges of the peritoneal dialysis fluid per day, with each exchange taking around 30 to 40 minutes. So the patient generally always has about 2 to 3 litres of fluid in their body at a time. The other way that we can do this dialysis is the automated peritoneal dialysis. This is with the use of the machine that you can see in this picture here. Now, these particular machines only require to be plugged into a normal power point. There's no special plumbing or electrical requirements. The patient has the dialysis every night for around 8 to 10 hours, so generally while they're sleeping, and it will run through around 6 cycles of that peritoneal, that dialysate fluid running into their abdomen. With this type of dialysis, we offer training at the St George unit, and that takes around 2 weeks. But if a patient is going to take longer, that's fine, or a patient may take less time. So for 2 weeks, they're usually coming in about 4 days. And while they're here with us, they get some gentle start to that dialysis. So then we don't send them home to have this dialysis at home until we know that they're well and truly independent and ready to do it for themselves. The patients, once they do go home, have 24 hours of help. There's contact details that they're given to contact during normal business hours. There's also contact details of who they need to contact outside of those hours. There's no cost involved to the patient provided they have Medicare. The machine itself is provided to the patient for as long as they require it, and all of the consumables are delivered to their home on a monthly basis. And if there's an issue with space, they can actually be cut back to only fortnightly deliveries as well. They also will have, if they live within the St George and Sutherland area, the nurses that train them will actually go out and actually do a home visit before they actually physically start having the dialysis at home. The other form of dialysis is the hemodialysis. Now, this can be done also at home or can be done in one of our satellite units. So St George has 2 satellite units, and then we have an in-centre unit here at St George Hospital. One of our satellite units is based next door to Sutherland Hospital, and we have another one here in Cogra that's down in Cogra Town Square. So for hemodialysis, the patient will need to have a fistula created. So this is where a surgeon will go in and he will join a vein onto an artery, and over around a 2-month period of time, that will develop into a large blood vessel that we're able to put needles into for dialysis. The other form of access we do have is a VASCath. This is a temporary access that if we haven't had time to have a fistula created, or we're having issues with creating a fistula, that we may have to use temporarily in a patient. With the hemodialysis, when done at home, we encourage the patient to do it every second day, and usually they're on the machine for around 4 to 5 hours. They can do it at any time of the day every second day, and it doesn't need to be that same time. They can change it around to suit their needs. If they're coming into one of our supported units, it's 3 times a week. And usually they end up on a schedule of either a Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday. So I normally tell the patients that they're going to allow then for around 7 hours out of their day, 3 times a week, if they're attending a unit. If it's also done at home, there is also the capacity for them to be able to do the dialysis overnight for 8 hours. With the home hemodialysis setup in this picture here, we've got the dialysis machine, and then we've got these smaller units, which are the reverse osmosis units, which filtrate the water quality in the home into a quality that the dialysis machine is able to use for dialysis. With home hemodialysis, because there's obviously a lot more involved, the training usually takes about 3 months, and it's the same sort of setup. They're coming in 4 times a week. and while they're here, they're having their dialysis. Their final week of training, they attend Sydney Dialysis Centre, which is our overarching unit that looks after our home haemodialysis patients. And that final week is like a graduation week where they put them through troubleshooting to see how they're going to manage this at home. And again, we don't send anybody at home that we know is not confident in doing the haemodialysis at home. There's 24 hours help for these patients with Sydney Dialysis Centre, and then also within hours they've got the opportunity to call the home training nurse, who is based at our Fresenius unit, which is the unit that's over in Cogra Town Square. There is some minor plumbing and electrical changes with the home haemodialysis that the patients need to make. They need to have an extra drain put in and an extra tap. They also need to have a separate circuit put in their circuit board and some extra power points to manage that medical equipment. We get the patients to pay for these initial costs themselves, but once they physically start having their haemodialysis at home, they're reimbursed by the government for a set amount of those costs. The only other cost that the patient will generally have for haemodialysis at home is that they will have to purchase a reclining chair and maybe some sort of table. And other than that, everything else is again provided to them as long as they are covered by Medicare. If they obtain letters from their kidney specialist, they can actually get some cheaper rates with their, I think it's with their water and their electricity. And also they can actually get a larger bin from council to be able to get rid of all of the extra waste. So I've just put in some case studies in here today. These are about patients that I've had in the past, just to give you a bit of an idea of the information that we gain from the patients at that first appointment in the pre-dialysis clinic, which helps me to build a picture along with the letters from the nephrologist to work out what's going to be the best form of treatment for this particular patient. So this patient here, he's a 51-year-old gentleman who had quite a high BMI. So that's already indicating to me that peritoneal dialysis may possibly be an issue. So we're already looking at haemodialysis as probably our preferred treatment. He's got a history of ischemic heart disease. He's had bypass surgery, non-STEMI. He's had issues with his blood pressure. He's diabetic and issues with high cholesterol. He has also had some abdominal surgery, a gastric sleeve. So the gastric sleeve combined with the high BMI, and he's also had that bypass surgery where they do occasionally breach the peritoneal cavity. I would need to send him then to a vascular surgeon to make that determination if PD would be something that we could look at. But on finding more information out about this gentleman, he was living at home with his wife. He had 3 teenage daughters and he was working quite excessive hours. He also didn't speak English, but that does not preclude him from having any sort of home therapy. It just means that we need to be a little bit more planned in making sure that we've got interpreters available during that training period. He's renting a 4-bedroom home. So the only other issue there is with renting is that the patients actually have to get permission from their landlord to be able to make those plumbing and electrical changes. We don't generally have issues with landlords not allowing that to happen. Quite often they'll just suggest that if the patient was to move out, that they may have to get those changes put back. And this gentleman drives. So for him working such long hours and working shift work, him to be able to do a home therapy is going to be the best form of treatment for him so he can work that around his working life. So some of the challenges which I've already highlighted was the fact that he was non-English speaking, that he was renting, his working hours and for training, and then obviously wanted to get him to have some weight loss. So from the working hours and the training, this is where we were able to involve the social worker who was able to help aid him with some resources in financial support while he had to have time off. Some of the reasons the other modalities wasn't suitable, peritoneal dialysis I have already explained. Transplant was also explored, but due to medical reasons and the high BMI, he was not a suitable candidate at this time. So this gentleman actually now continues on home haemodialysis successfully, and he can still work full time and perform his dialysis at a time that suits him. And I'll hand over to Brendan.
Okay, thanks, Kylie. So I suppose you're wondering as well that is there any difference for patients depending on the modality they choose? You know, you want to give your patients the best advice. If they ask you, what should I do? The response really is that home therapies are always preferable if they can be achieved. And if you actually look at the survival data, and this is some analysis that we did using data from New South Wales, it's a little bit old now, but the national data would suggest that this hasn't changed. And the takeaway from this slide is that patients doing home haemodialysis do a lot better in terms of survival than their comparators on in-centre haemodialysis. So that's haemodialysis at one of the satellite centres or at the hospital, or the people on peritoneal dialysis. Now, quite a bit of this difference is going to be just that selection bias, that, you know, it tends to be younger, fitter patients who are able to manage home haemodialysis, whereas your older, frailer patients can't quite manage it and so end up doing in-centre dialysis. But that's not the whole story, and it's not just that selection bias. The ability to do longer hours, more frequent dialysis that can be tailored to the symptoms that the patient has or their physiological needs makes a difference. When it comes to in-centre haemodialysis versus peritoneal dialysis, there's no difference. I mean, you can see here a bit of divergence in the lines, but that's not significant. And if you look at studies around the world, you know, no one's ever been really able to show that peritoneal dialysis and haemodialysis have different outcomes. So again, to stress that the fundamental recommendation is to try for a home therapy, whether home hemo or PD. Next slide, thanks, Kylie. And here again, I suppose it's reiterating what I've just said. It's the meta-analyses that have pulled a whole lot of observational studies. And you can see down the bottom there that bottom diamond doesn't cross one. It really shows that while there are some studies that have divergent views, if you pull them all together, essentially you get the consistent message that PD and in-centre haemodialysis are more or less the same in terms of survival. Next slide. People sometimes worry about infection risk, I think, and we've had some feedback from GPs that, or from patients who've been told that they shouldn't do peritoneal dialysis because of infection risk. Both hemodialysis and peritoneal dialysis are associated with a low risk of infection, usually around the PD catheter or fistulas or hemodialysis catheters. Those risks, however, are much, much lower than they used to be. And that's as a result of people like Kylie, you know, implementing, you know, strict training programs, providing clear advice and better technology to patients. The current rate of peritonitis, so infection associated with PD in New South Wales, is 0.5 episodes per year. So maybe one infection every 2 years. That's an average. And so much of that's probably driven by a handful of patients who have poor technique, and which we work hard to try for, but to try and correct. But many patients go years without ever having an infection at all. And I put at the side there a slide about the use of peritoneal dialysis in other countries. And it's the most prevalent modality of dialysis in Thailand, and Hong Kong's 70% peritoneal dialysis. And those countries, you know, if they can manage it with lower resources, you know, it's clear that we can and do manage peritoneal dialysis very well in Australia. So yeah, if your patients hear about that, I think you can reassure them that the risk of infection is low. Next slide, thanks. And Kylie, I'll get you to present this next case study. And again, keep any questions, just pop them in the chat.
So our next patient is a 79-year-old lady who has a BMI of 34.2. She's got sort of minimal sort of medical history. She's got quite extensive abdominal surgery history, so would more than likely deem her as not being suitable for peritoneal dialysis. She lives with a husband. She has a 3-bedroom home that they own and reside in. She still drives. She's a self-funded retiree, and she's got 3 adult children, not living with them, but it just indicates to me that she's got quite a good support network. And she speaks English at home. So some people may look at her age and think, well, no, supported dialysis is probably what she would need to do, but that actually isn't the case. So Mrs. W did have some challenges. She didn't have great veins for creation of a fistula, but she did eventually get a fistula created. Her age and training, obviously a challenge with learning the technology required for home hemodialysis. And she did actually have an extended training period. She couldn't have a transplant due to her age. Peritoneal, as I've explained, her abdominal size and multiple surgeries. And conservative was discussed with Mrs. W. And if that is something that she had elected for, and if her nephrologist had felt that this was something that would be more suitable for her, then that obviously was an option that she could also explore. Mrs. W actually is still on home hemodialysis. She is now 83 or 84 and has successfully stayed on home hemodialysis during her time with the assistance of her husband at home. Mrs. W obviously was lucky that she has got her husband at home, and if she had lived on her own, it may not have been something that we could have made happen for her, but because she did have that support at home, she had this willingness to learn and she wanted to be at home for dialysis, we were able to successfully have her dialysing at home, which has kept her out of the hospital during challenging times of the last 2 years, where a lot of patients in that age bracket have been quite apprehensive about having to come to the hospital for dialysis for the risk of contracting COVID. Brendan, I'll hand back over to you.
Okay. Yeah, so I've mentioned a bit already about the advantages of home hemodialysis and that ability to tailor the dialysis, particularly home hemodialysis, or both PD and home hemodialysis, can be varied a lot more than in-centre dialysis to meet the needs of the patient. More dialysis or more intense dialysis can reduce the need for phosphate binders, which are sort of big, ugly tablets that we make them take, and they may not need them if they're doing more dialysis. Reduce the need for antihypertensives. You get better control of bone health markers. You're not getting those extreme shifts in fluid status. You know, if you're doing 3 times a week in-centre hemodialysis, you know, you've got to come in and have 3-4 litres of fluid sometimes ripped off in a 4.5 hour session, which is a massive strain on the heart. If you can do your dialysis at home, you can avoid that. You can do more frequent sessions or longer sessions, and so you're not placing that strain on the cardiovascular system. More frequent dialysis or longer hours is associated with better quality of life. And I was really interested to see, I was at a conference just on the weekend, and there were a number of patient representatives, many of whom had done home hemodialysis. And the purpose of the conference was to talk about symptoms. And some of these patients were saying, look, I've just never really had any symptoms. They've been doing home hemodialysis for 5-10 years. And, you know, one of them was like a skydiving enthusiast or something. You know, you really can live a full life with some of these dialysis modalities. Now, sort of practical issues do come up, of course, and there is now a program that provides assisted home hemodialysis. So we work with a private company, and it's partially funded by the government, although the patients do need private health cover to access it, I think, because it's also subsidised by the private system. But they'll have a nurse come and deliver their dialysis. at home. They've got to have the home setup, of course, but that also provides a sort of a halfway house for some patients who may not quite be able to manage home hemodialysis independently, but we can give them many of those benefits with home therapy. Now, I've just put a quote in here from a paper that really summarizes the advantages of home hemodialysis. It brings out, the anxiety issue as well. And if I just read it out, patients and caregivers perceive home hemodialysis to offer an opportunity to thrive, to improve freedom, flexibility, and well-being, and strengthen their relationships with the people around them. However, some do voice anxiety and fear about starting home hemodialysis because it is a bit confronting. The fact that they're doing this in perceived isolation from medical and social support is a barrier. But, what Kylie does and what our home therapies training nurses do is acknowledge these factors and their apprehensions. And so we do help them to overcome their fears sometimes. And I think for this reason, home therapy should be the default. The next slide, thanks. One of the other reasons besides patient preference and the advantage of quality of life is simply cost. Home therapies are substantially cheaper. You're talking sort of $45,000 to $60,000 a year for PD or home hemodialysis versus $85,000 up to $100,000 a year for in-center dialysis. And, here we're talking about costs to the healthcare system. And, ultimately, if we can manage dialysis more effectively and more cheaply, there's more money available for, for other things for these patients and for the rest of your patients as well. There are extensive subsidies available, and Kylie's already touched on that. So although there's some small upfront costs, most of that is reimbursed. There's energy and water bill discounts. So most patients are not worse off. Next slide, thanks. And training for home hemodialysis with a home hemo or home PD is an iterative process where, we assess how the patients do. We introduce them slowly. We train them, test them, retrain them. It's not a sort of boot camp, and the other thing I'd emphasize is that we still sometimes find it hard to pick who will and won't manage home dialysis. The best way to assess suitability is just to put people in the training program and see how they go. We are often can be surprised at people who you think, oh, I'm not quite sure, end up thriving. So our programs for training are structured and they're comprehensive. Before patients go home, we ensure that they are able to do the therapy safely and independently. And even when they are at home, they have an on-call service available and so are well supported. We do sometimes fail people, it's not like, we don't want people to go home and be unsafe. And so there are people where we sometimes say, look, actually, no, this is not for you, but that's uncommon. And in any case, in a sense, that's also not a failure. It's better to have put someone up and we work out that actually it's not right for them than to just not try at all and assume that it's not right for them when perhaps it could have worked quite well. Sometimes we involve family and carers, as that can be an important way to facilitate home dialysis for some patients. And I think, the image of the bloke on the side there, you don't know who's going to be able to do well on home hemodialysis. It doesn't matter about your educational background, what language you speak. Most people can do it. Next slide. Obviously, patient choice is really important, and there's a whole lot of factors that go into this. I think two key takeaways for you guys out of this talk are that, firstly, if your patients are talking to you about, oh, my doctor thinks I need to start dialysis or whatever, I think we'd like it if your attitude was that a home therapy is the default choice, and so that message is reinforced by other healthcare workers. The question that we ask is not, can this person do home dialysis? It's just, why not? And what are the barriers and how can we overcome them? It's important also to stress that there's very few absolute contraindications to home therapies. And most of the time it's a holistic assessment where you've got an assessment that Kylie and her team make of pulling together information about, well, what are the housing factors here? Are they renting? How much space do they have? Their health literacy, any cognitive issues, what's their history of compliance with therapy? Are they sort of physically able to do it? Some comorbidities can play into it. Also social factors. And you sort of pull all that together and think, well, okay, look, maybe there are some barriers here, but what can we overcome? And often we can put in systems or tweak things so that people can do home therapies and do that successfully. Next slide, thanks.
So our final case study today is a lady, a 67-year-old lady who come to clinic, and you can see her past medical history there. Apart from her open total hysterectomy, there wasn't really anything too much that would preclude her from being considered for peritoneal dialysis. She lived at home. She was a retired nurse. She did speak Greek, so we have a bit of a challenge there with the language barrier. I'll just move on to the next slide. So the challenges that we did have with this patient, though, is she was extremely apprehensive about having a home therapy. And with patients that are like this particular lady, it was just important that we were spending more time in clinic. So generally with the pre-dialysis clinic, we'll see patients for the first appointment, and then they'll come for follow-up as they require it. But in this lady's case, we brought her back a few extra times just to slowly give her the information and slowly build up her confidence in her being able to have the peritoneal dialysis at home. The language barrier being that it was predominantly Greek with a very small amount of English. We had to get our peritoneal dialysis resources translated into Greek for her to be able to use. The automated peritoneal dialysis machines actually can be changed into other languages. So we were able to have that changed into Greek. And then we had an interpreter or family present during the training period, which helped overcome that barrier. Her support network, although she did have her husband at home, he actually wasn't willing to partake in any of the education or anything associated with the dialysis. He actually didn't attend any of the appointments with her. So I think a lot of her apprehension also did come with the fact that she felt like she was doing this on her own. So we had to overcome that with providing her with ongoing support and, as I said, the continual follow-up with staff. She was very capable of being able to perform this treatment, and we knew that. We just needed to work out how we were going to overcome these issues. She did have the previous abdominal surgery, and she was seen by a vascular surgeon who actually did deem her as being suitable to be able to have a peritoneal dialysis catheter. She did have a fistula created at the same time, just in case that there was issues and that peritoneal dialysis didn't work, and we had that backup access if we had to transition over to the hemodialysis. Transplant's also a suitable option for this lady. Unfortunately, she had no donors, so she was listed onto the deceased donor list, and then she'll be entered onto that waiting list. Home hemodialysis and supported dialysis were also options that this lady could look at in the future if for some reason the peritoneal dialysis doesn't continue to be successful. So she started dialysis this year, and so far to date, she's continuing having her dialysis at home, and anxiety seems to have settled for her. Is there any questions? There was one question that was raised from the last presentation in relation to this presentation, and that was about how or who GPs contact in terms of troubleshooting. And I'm just going to move on to the next slide. So for general practitioners, the best contacts you will have in terms of home hemodialysis patients are those CNCs listed below. But ideally, if it's after hours, we would sort of be encouraging the GPs to get in touch with whoever the on-call nephrologist is. The patients actually get given information on 24-hour numbers of who they need to call within hours and with outside of hours if they're having issues with their dialysis, but they're predominantly patient contacts. So ideally from the general practitioner perspective, we would be encouraging you to get in contact with, as I said, the renal department, and in hours you've got your CNCs and then just contacting through the department, and obviously outside hours you've got the on-call nephrologist who you can get in contact through switch. That's probably the best way to sort of describe who would be best to contact. I know all the CNCs within the department happily facilitate any general practitioner questions or any issues that you might be having with any of your patients and put you on to the right person that you would need to talk with. The next slide is just the health pathways that are currently live. And we've got our acute kidney injury, we've got chronic kidney disease, we've got the referral, and the rest you can see there. So all the details of where to log in for that are on that page. And we have just our reference list there. And as I said, is there any questions?
There is, yeah, there's a question from Martina.
Okay.
Hi, Martina. So what kind of creatinine levels are acceptable for people undergoing home dialysis? So once you get onto any form of dialysis, creatinine becomes close to irrelevant. Every time you do a dialysis session, you're washing it out of the blood. And so if you were to graph creatinine over time, like say, during the week on someone who's on hemodialysis, it'd just be doing this all the time. You really don't get much of a sense of, well, it really doesn't mean much anymore. And an estimated GFR is also meaningless once you start dialysis. What becomes important is symptoms, fluid status, so blood pressure, are they fluid overloaded? Appetite, serum albumin is sometimes a good marker there too. I mean, if people are starting to drop their albumin, you do sort of worry that they're becoming malnourished. Markers of bone and mineral health, so we pay some attention to phosphate, anemia, of course, although it's less affected by quality of dialysis and more just by how much EPO and iron we sort of give them. But once you start dialysis, you sort of shift from looking at eGFR and creatinine to, looking at a whole host of other things in order to try and work out how much dialysis that patient needs. And it changes over time. When someone starts dialysis, they almost always are still producing urine. I mean, if you're completely anuric, then you absolutely need dialysis, but most of our patients gradually progress towards needing dialysis. And so they may be producing, a normal urine volume, but that gradually fades away. In fact, it fades away quicker on hemodialysis than on peritoneal dialysis, which is potentially one advantage of peritoneal dialysis is patients maintain their residual urine output. But part of our assessment too factors that sort of stuff in. If someone's still producing a fair bit of urine, then they probably don't need as much dialysis because they've still got a little bit of residual kidney function. They're still able to clear a little bit of fluid. But as they progress towards becoming oligoanuric, they may need more dialysis, and so you can increase their hours, or if they're doing home dialysis, have them do second daily. With peritoneal dialysis, you can change the fill volume and the sort of the pattern of exchanges that are done. So there's a whole lot of ways you can fiddle with the regime to try and optimize the patient's well-being. But yeah, the bottom line is that creatinine doesn't really mean anything.
I guess a take-home message for the GPs as well is how much information they want in terms of home, like what therapies the patients are looking to look at in the future. I'm more than happy to have GPs ring me after they receive those letters that from the pre-dialysis clinic that talk about treatment options, particularly if they've got something that they might want to add in terms of a patient's social background. I really do try and look into that as much as possible, but patients tend not to do a whole lot of talking about social backgrounds when they don't know somebody. And I'm usually meeting them for the first time and asking them all these questions, where with the general practitioners, they're seeing patients for quite a number of years and developed quite a nice rapport with the patient where they'll be more open. So I would definitely invite general practitioners to feed back any information in regards to maybe what they think is going on at home, in case that's something that would also then play a part in them having a home therapy.
Yeah, definitely second that. I mean, you know, if you guys know your patients really well, and so, yeah, if you think that if you're worried about a particular therapy in a particular patient, then by all means, yeah, let us know. We want to make sure that we're communicating with you guys, and you know, we don't send a patient home when they're not ready, or if the dialysis is causing some problems that we're not aware of, let us know for sure. And Martina's asked another question about whether, and in dialysis patients who are anuric, can they get a UTI? I'm going to say no in general, in that you know, you really don't see that. But I won't say, yeah, basically no, I think. There's always sort of odd events where you've got someone who might end up with some sort of, I'm trying to think if I've ever seen it. You know, you never want to say never in medicine, but basically we don't see that. You know, if we have a patient who's, you know, you do have dialysis patients who are anuric and they come in and if they've got a febrile illness, you know, you don't go and put a catheter in them or something. If they're anuric, you know, we treat another potential source. So short answer, no, I think.
Any other questions? Bertha and Lauren, I might hand back over to you if there's no other questions.
Thanks, Kylie. It doesn't look like there's any more questions coming through currently. So I just wanted to thank you all for attending. And just a reminder, next month's St. George topic is sexual health on Tuesday, the 14th of June. Thank you.